Hello everyone, let's give some more minutes, couple of minutes so people can join. Then I'll be starting with our anatomy 3D. Mhm. Good evening, everyone. In fact, evening in some parts of the world, and some parts of the world it's night. So, if I say good night, you will feel like the class is over. So, I can't say good night. So, we'll start with our 3D model from abdomen. So, first, we'll start with abdomen. So, you don't need everything. You don't need everything, but you have to have an overall idea of your anterior abdominal wall. So, the shiny object you are seeing is not gold, it's rectus sheath. Okay. So, this is rectus sheath, this is rectus sheath. Now, it's like a sandwich, like one bread, rectus sheath, anterior rectus sheath in front, and let me show you. We hide it, hide it, and so what's the point? First, I will show you everything and explain everything from this 3D model, and then we will go to our notes. So here you can see that inside your abdomen, from behind, we can see that this is the posterior rectus sheath. But see, this is half. This is not full. At the lower end, there is no posterior rectus sheath, only anterior rectus sheath. Okay, only anterior. So just see. Okay, just see. Then, if we hide this, we can see rectus muscle, rectus abdominis. This is our rectus abdominis. Okay, this is our rectus abdominis. That's it. Nothing else needed. Just see. Okay. Then we will go to, I will add all the muscles again. So laterally, we have external oblique muscle, and the white part is the aponeurosis. Origin, insertion, action. You don't need it for part A. Not at all. You don't need it at all. So remember, first see the layers. First, ab- external oblique. We hide it. Then we have internal oblique. We hide it. Then we have transverse muscle, that is transversus abdominis. Three layers. Then we have fascia transversalis, which we cannot see here. Now we are going behind again. See, if we see from behind on the opposite side, we can see this opening. Okay, so this opening is deep inguinal ring, and it's a defect in fascia transversalis. Fascia transversalis. Now, see what is above. What is above? What is above the ring? See this one, transversus abdominis. So it's above the ring. So if this is a deep inguinal ring and the canal is going in front, and at over it we have transversus abdominis. Okay, we have transversus abdominis. Then if we hide transversus abdominis from inside, we can see this is internal oblique. So both of them you are seeing that it's over this, and the canal is opening. Okay, this is inguinal canal. Okay, this is inguinal canal. This is our deep inguinal ring that's starting, and then the canal. First we could see just this part. Then after we remove transverse abdominis, which was this cut portion, you can see, we can see that this was your transversus abdominis. Then right now we have internal oblique, right? See, so this is internal oblique, and these two, internal oblique and transversus abdominis. Internal oblique and transversus abdominis makes a common tendon that is called conjoint tendon. Conjoint tendon. Now, see, if we remove internal oblique, we can see external oblique aponeurosis, and we can see the canal right now. So, this is our inguinal canal. So anteriorly, we are having this external oblique aponeurosis, and over it on the roof, we had two muscles, that is internal oblique and transversus abdominis. And behind it, we had fascia transversalis. Fascia transversalis. And you can see the more medial this canal is coming, this thing is now posteriorly. This thing is now posteriorly, posterior to the canal. See this? So easy, right? And we get confused about it because I was not there for you. You can see that we hide this linea alba thing. We hide it. Now you can see that this is the canal. We hide it. We don't need it. We hide it. So now this is the canal. We can see the canal. If we see from front, we can see external oblique anteriorly. Internal oblique and transversus abdominis was over the canal. So we can call it roof of the canal. So the roof would be internal oblique and transversus abdominis. And behind here we had posteriorly or behind fascia transversalis. Then now we have this canal is here, and we have conjoint tendon. Conjoint tendon behind it. Okay. So this is the boundary of our inguinal canal. Do you know the length and all these things? No. First, see whatever I am showing you. Then you have to know the contents. Spermatic cord and round ligament of uterus in case of female. So they don't ask about the contents. What are the contents? Let me tell you what they ask about. Let me add the arteries. Then let me add the no need of veins. They don't ask nerves. They ask about nerves. Okay. So we can see some structure. Let me add urogenital structures. Okay. So you can see that some structures are entering the inguinal canal. Okay. So this is our testicular artery. We didn't add veins, only the important ones you can see. This is our ductus deferens. Now remember, ductus deferens is not entering. Okay, it's coming out through direct inguinal ring. Okay, it's coming from the scrotum. It's coming from the scrotum. Okay, then you can see a nerve inside. Then you can see a nerve that's see that's inside abdomen, but this is the deep inguinal ring. This is not entering the deep inguinal ring. This is bypassing the deep inguinal ring. For now, let me hide this thing. And going over the deep inguinal ring. It does not enter the deep inguinal ring. It's over the spermatic cord, or it does not enter the deep inguinal ring. Now, do we have any other nerve? Which one enters? Remember, genital branch of genitofemoral nerve enters the deep inguinal ring. We have another one. That one is not important. That one is not important. So the structures are genital branch of genitofemoral nerve, testicular artery, and we have venous plexuses. We don't need it now. We have ductus deferens. Okay. So let me tell you another thing. That is, these are the structures that are entering deep inguinal ring, and ilioinguinal nerve is sitting over your spermatic cord. It does not enter deep inguinal ring. And it will come out like this and will give anterior scrotal branches, and that will supply now that will supply the anterior part of scrotum, and the lateral parts are supplied by genitofemoral nerve. That's not important, they don't ask. First, see, and everything I'm telling you, everything is very specific, and they ask you questions from only from these areas. Okay. And genital branch of genitofemoral nerve will supply your cremasteric muscle and will give cremaster. Let me add the muscles. No, we cannot. So cremasteric muscle and will give you cremasteric reflex. Okay. And posterior scrotal nerves are coming from posterior femoral cutaneous nerve. So posterior supply of the scrotum is coming from posterior scrotal nerves. From okay, from perineal nerves and pudendal nerves. Okay. Okay. So posterior Scrotal kin is supplied by posterior scrotal nerve. Just remember it for now. Now, they will ask you the boundary of inguinal canal. How they will ask you the boundary? They will tell you that while entering for hernia, what's the first structure you have to divide? Okay, so first thing is anterior. So you have to divide external oblique because we can clearly see that if we cut, so if mm, so if we give an incision here, we can see that the inguinal canal is opened. Okay, we can see that the inguinal canal is opened. So first layer we have to cut is external oblique aponeurosis. Sometimes they ask you directly about the roof, and sometimes they ask you directly about the posterior structure. Now, second thing, and most commonly asked question, medial and I mean, let me just open it. Okay, we have to say again from side. They will ask you only about direct and indirect inguinal hernia. Only about direct and inguinal. Others they will never ask. Never. And if they ask, I will tell you. So you can see here. Okay. You can see that the direct inguinal ring, guys, the deep inguinal ring is somewhat lateral to your inferior epigastric artery. Okay. Lateral to your inferior epigastric artery. And you can see this is lateral and this is medial. This is our inferior epigastric artery. Okay. So if a hernia goes inside the direct inguinal ring, inside, inside, we call it indirect hernia. Remember, inside, indirect. And if a hernia is through this wall, that is medial, medial, me, D-I-A-L, medial, D, medial to inferior epigastric artery, that is called direct inguinal hernia. Simple, specific, easy, and they will always ask you in relation to this artery. Always, always, if they give you a question, they will give you a question from this. And they ask you another question, that which artery crosses the external iliac artery and enters the deep inguinal ring. So the only artery entering the deep inguinal ring, that is testicular artery. Okay. And this is external iliac artery. This is external iliac artery and this is our testicular artery. It's going over the external iliac artery and enters the deep inguinal ring. Then, then let's go inside. We hide it. We hide the arteries for now. We hide the nerves for now. See, so easy. So easy. This, like inguinal canal, we had it so tough. We feel like we can't remember. But this is so easy. If you know how to study it, if you can see it, you can always remember it. So now I'll be adding the abdominal organs and showing you all the important organs from abdomen and pelvis. Let me add digestive. Okay. So abdominal organs, let me tell you what are the things that are important. The most important thing, the first important thing. A lot of most important things we have. The first important thing is stomach and its blood supply mainly. Okay, so let's hide hepatic gastric ligament. So I'll show you on important things. All of the important things will be shown, and whatever I show you, that's very important. Then we'll go to notes and tell you what to study and how to study. Okay. So first thing you need to know is the blood supply of stomach and how they are going to ask you questions. So for that, I'll be needing the arteries. So from abdominal aorta, we have celiac plexus. Celiac means sun-like, and it will have three rays. One, two, three. Okay. It will have three rays, celiac sun-like, at the level of T12, just after crossing the aortic hiatus. Okay. So this is the first thing, that is left gastric artery. You can see it very clearly that it's supplying the lesser curvature of the stomach. We hide it. So it's supplying the lesser curvature of the stomach. So if you have any ulceration at lesser curvature, they ask you that you are having an ulceration at lesser curvature of stomach. Which artery is responsible for the bleeding? Left gastric artery. So knowing that lesser curvature is supplied by left gastric artery is anatomy. And knowing an ulcer along lesser curvature is bleeding and the bleeding artery is left gastric artery is called surgical or applied anatomy. So that's the difference between anatomy and applied anatomy. Then, and we have to look at another thing, that it has, see, it has a little branch that's not here. If I add the branch, you can see that it's supplying the lower part or abdominal part of esophagus. See, the blue one, lower part or abdominal part of esophagus. So we have esophagus in our thorax. So if, and I will, if we have an esophagectomy of upper two-third, the rest of the esophagus will be supplied by this artery. That is a branch from left gastric artery. They will just ask you which artery, this one, that is left gastric artery. So you get only two questions. There is nothing else than that to ask from here. And they will always, because these are important. These are important. That's why they will ask you from there. They will not ask you about some random branches from the abdominal aorta. No, they will not ask you that. Okay. So the second one is a tortuous artery. That is very tortuous. Like for that, let me show you from this side. See, see how lucky we are at the to be studying anatomy at this age. So this is called tortuous splenic artery. That means if we start going, we can see that this artery will be supplying the spleen. So see, celiac plexus will be supplying all the structures from foregut except one organ, that is spleen, because spleen is derived from mesoderm. Mesoderm. This is not a part of foregut, right? So this is a very important point to remember. They have asked it several times. So tortuous splenic artery will supply spleen, and another thing is we can see that here is the upper part or body of pancreas. So inferiorly we have body of pancreas, and here we have our suprarenal gland. So we have anteriorly. Splenic artery is anterior to our suprarenal glands, like left suprarenal gland, not suprarenal glands. We can say it. See, where is suprarenal gland? Oh, I didn't add it. Okay, just remember it. So this is about splenic artery. Then we have this one, that is common hepatic artery. That is very important. So I have to add the branches of common hepatic artery. See how many branches? Too many branches, guys. So one by one, let's talk about one by one. So this is our, okay, let me show you one by one. Okay. So the first thing you need to remember is gastroduodenal artery. So common hepatic artery, first it will give gastroduodenal artery. Then it will give right gastric artery that will supply our pylorus or pyloric antrum. Okay. So this is a small artery, right gastric artery. Then if we go behind, let me show you from behind. So if we go behind, give me a moment. Let me remove this. So here we have it. This is important, guys. This is very important because you have questions from these areas. So we can see that this is going down. That is gastroduodenal artery. We hide it. We hide it. Let me just hide it for now. So this gastroduodenal artery will go down and give some branches. That is right gastroepiploic artery. So this is our gastroduodenal artery. You can see that it's behind the first part of our duodenum. Gastroduodenal artery, first part of duodenum. Gastroduodenal artery, first part of duodenum. After crossing it, it will give right gastroomental or right gastroepiploic artery. I'll show you from in front. So why am I stressing on this so much? Because any ulcer from any bleeding from first part of duodenum is from gastroduodenal artery, and that's the most common site of ulceration. Most common site of ulceration. Okay, so our job is done from behind. Now we will come in front again. So now as we have seen that gastroduodenal artery supplying giving our right gastroepiploic artery. See, this is our right gastroepiploic artery supplying the pyloric end and near greater curvature. Okay, the pyloric end near greater curvature. So any ulcer along this area and bleeding, responsible artery will be right gastroepiploic artery. Then we will come to the greater curvature left part. So we can see that our torsus splenic artery is going behind. This torsus splenic artery will give two arteries. That is left gastroepiploic artery, two important arteries. And another one is short gastric artery. Where is our short gastric artery? So these are splenic branches. Here is our short gastric artery. You can see that little, very short gastric artery. Okay. And this short gastric artery is supplying our fundus of the stomach. Short gastric arteries are supplying our fundus of the stomach. Now, why is that important? See, accidental spleen injury is very emergency situation. Now, if we add the lymphatic system, we can see the spleen. So here is the spleen and we can see that splenic artery is supplying the spleen. We all know the splenic artery will supply spleen. Very, very simple and understandable. So, and this short gastric artery are coming from splenic artery. Now, short gastric artery is giving splenic branches, and from splenic branches we get short gastric artery, splenic artery, splenic branches, and from splenic branches we get short gastric arteries. Now see, if we get an injured spleen and we need to do a splenectomy, so we need to do a splenectomy. So if we do a splenectomy, we have to ligate this splenic artery. Then again, if we do a splenectomy, our fundus of the stomach will lose its blood supply, because when we remove the spleen, will we keep the blood vessels of it? Answer is no, no, we won't. So our fundus of the stomach will lose its blood supply. So that's a question you get asked frequently. That's the question you get asked frequently. Guys, please stay mute. Now we are going deeper. We are going deeper. See, this is our splenic artery. Now, if we add endocrine system, we can see that this is our pancreas is just below pancreatic body, just below the splenic artery. Now, guys, see, if we do a splenectomy, we have to ligate. We have to ligate. So during ligation of splenic artery, this part, that's the tail of pancreas, is going to be injured. And because why do we do a splenectomy? Splenic rupture, there is massive bleeding, and you can be very, this is very easy to injure the tail of pancreas. And you always get this question in MRCS part A, that during ligation of splenic artery, which organ can get injured? That is tail of the pancreas, because we will clamp it here. We will clamp it here, and the tail of pancreas will get injured. What's the problem if tail of pancreas can get injured? Guys, pancreatic necrosis, and we lose insulin. Why? Because the beta cells of pancreas are present in the tail. Most of the beta cells of the pancreas are present in the tail of the pancreas. And that's why this is very important and we have to know it. And of course, that's why they ask you that what's under the splenic artery? That's pancreas. And this is our suprarenal gland. You can see that it's somewhat anteriorly. It's somewhat anteriorly to the suprarenal gland. Now, our stomach blood supply is done. Okay. So here we had common hepatic artery, and from here we get gastroduodenal artery. From gastroduodenal artery, we get right gastroepiploic artery, which supplies the greater curvature of the stomach near pylorus. And the next branch is right gastric artery, and then comes proper hepatic artery. That is purely hepatic. That's why it's properly hepatic. This one is common hepatic. Yeah, there are hepatics and proper hepatic. Okay. So this is our proper hepatic artery. We get two arteries from here, left hepatic and right hepatic. And right hepatic artery will give you cystic artery, that is the artery to the gallbladder. The artery to the gallbladder. So this is very important that cystic artery is a branch of right hepatic artery. Why? Because as a surgeon, you will be doing a lot of cholecystectomy and you have to clamp this artery. If you don't know that it which artery gives this branch, so that is a little bit sad. So now I'll be adding some connective tissue. Fascia transversalis removed. I had to show something. Okay, leave it. I'll show it later. Then I'll be adding veins. Okay, this is important, guys. Don't blame me for this mess. Nothing else needed. Just the veins are needed. Give me a moment. Okay. So we are back again into the first model. We hide it. We hide it. Oh, no. Okay. This one. We hide it. So you can see that there are some ligaments. When we do cholecystectomy, if you have seen open, good. But these days we always do laparoscopic cholecystectomy. So you might have assisted laparoscopic only. So you can see, you have to see something. So here are some ligaments from liver to stomach. That is hepatogastric ligament. From liver to duodenum fast part. Okay, that is hepatoduodenal ligament. Okay. Now, the thing you need to know that this hepatoduodenal ligament is the free edge of lesser omentum. Okay. Behind it, we have the lesser omentum. This hepatogastric ligament and hepatoduodenal ligament. Behind it, we have lesser omentum. Now, inside this hepatoduodenal ligament, the arteries I have shown you are inside this. But not only the artery. See, I'll be hiding it. So we can see common hepatic duct and cystic duct making bile duct. So common hepatic duct and cystic duct making bile duct. It's inside the hepatoduodenal ligament. And we have proper hepatic artery. We have proper hepatic artery. We can say just hepatic artery. Then we have portal vein. So you must know the serial. We must know the serial. If we go serially, we will see that hepatic artery, bile duct, and portal vein. Portal vein is the most posterior. Hepatic artery and bile duct are almost on the same level, but hepatic artery stays slightly anteriorly. Okay. So in hepatoduodenal ligament, we have three structures: hepatic artery, bile duct, and portal vein. So portal vein is the most posterior structure, and these are enclosed in hepatoduodenal ligament. Very important. Now, during cholecystectomy, if you get a bleeding, if you get a bleeding, you can do one thing, that you insert your finger inside. You Let me show you from sides. You insert your finger. You insert your finger and press this hepatoduodenal ligament. Insert your finger and press this hepatoduodenal ligament. Now, why this works? Because hepatic artery gives only 25% of liver blood supply, and portal vein gives rest 70 to 75% of hepatic blood supply. And we have both of these inside this ligament. If we press this, this bleeding can be managed. So this is called Pringle's maneuver, and that's why they ask you about this thing. Now, what's the most posterior structure? Portal vein. Now they will ask you, if you insert your thumb here and index in front, what's behind the thumb? Guys, this is a very beautiful question, and I love this question. Guys, see, behind that we have our inferior vena cava. Behind that we have our inferior vena cava. See, behind that we have our inferior vena cava. So see, behind that we have our inferior vena cava. So big inferior vena cava. See, so this is our hepatic portal vein. This is our bile duct, and this is our hepatic artery. Hepatic artery, bile duct, portal vein. So these three are inside hepatoduodenal ligament, and behind it we have inferior vena cava. Okay, so do you need anything else from liver? No, you don't need anything else. There are some other small things, they don't ask much. We will see those things. Now we are going to duodenum. What do you need to know? You need to know the relations of duodenum. Very, very important. Let me hide the veins for now. And let me hide some arteries for now too. So this is our duodenum. This is our duodenum. You have to know all the relations. Okay, so you can see that we can divide it into four parts. First part, second part, third part, fourth part. Okay, so first part, anteriorly we can clearly see gallbladder. Okay, then we can see behind we can see bile duct, and we can see gastroduodenal artery. Okay, behind we can see bile duct, gastroduodenal artery. Then only the important ones, the ones they ask you questions about. Then here we have in the second part, and we have kidney. I can, let me hide it, let me fade it. No, we have to hide it. Okay, let's hide it. So we can see the kidney. We can see the kidney. Suprarenal gland is above. Okay, right suprarenal gland. So it can be behind, or only the kidney can be behind. Okay, but we can have, so here we had the first part, this part. So behind important things are kidney, bile duct, gastroduodenal artery, and head of, upper part of head of the pancreas. See it, just see it. We have it all written in our book. Don't worry about it. So this is the first part of duodenum. But most important question from first part of duodenum is the most common site of bleed. Most common artery that bleeds. Now, second part of duodenum. Let me add duodenum again. Okay. So second part of duodenum. What are the important things you need? You need medial relation. That is pancreas. That is head of the pancreas. Okay. And you always have a question that which structure is posteriorly situated in both second and third part of duodenum. Let me show you the structure. We hide pancreas. So you might be wondering, do you know, do you think, what about pancreatic duct and all? You don't need those things. They don't ask. Veins, this one. See the structure? Inferior vena cava. So inferior vena cava is behind first part, second part, third part, all three. All three. Inferior vena cava is behind all three parts of duodenum. First, second, and third. So this is very important. Very, very important. Okay. So if we hide it, we can see that behind second part of duodenum, we have renal pelvis. And of course, where is the vein? Oh, I didn't add it. Okay, let me add the vein too, so you can see it properly. So we have hilum structures, kidney hilum structures behind second part of duodenum. We can see right renal vein. Then we have renal artery. Then we have renal pelvis. So all three will come posteriorly to second part of duodenum. Okay, and bile duct opens here with ampulla of Vater, inside ampulla of Vater, not important for your exam. Okay. So remember these three structures and inferior vena cava. is a common relation of second and third part of duodenum. Fourth part, they don't ask anything. So here you don't have to give so much effort for that. Let me show you what you need to give effort. I'll show you all these things and then we will move on to our notes. Let me hide it. Let me hide the arteries. Hide the veins. Okay. So not important, just see jejunum. Then we have ileum. Then we have cecum. Then we have ascending colon. We all know. So duodenum, jejunum, ileum, ascending colon, transverse colon, and mm, okay, we can see it. So then we have to add arteries. So why do we need to add arteries? Because you need to know some blood supplies of colon. Okay. See, here is our cecum and we have our appendix here, but in this model they didn't. They added one appendix that is behind. We cannot see it properly. We can see it from this side. So this is the appendix. Okay. That is in retrocecal position. That's the most commonly found position. That's why they gave it there. Don't worry about it. They don't ask about positions. They don't ask. Don't worry. But you need to know the blood supply. So this is our cecum and this is our ascending colon. After that we have transverse colon and then we have, and this is the second branch of our from our abdominal aorta. I'll show you all the branches, don't worry. That is superior mesenteric artery. Okay. Superior mesenteric artery. I'll be adding the branches. So here are the branches of superior mesenteric artery. But you need to know the branches of colon from superior mesenteric artery. So number one, forget posterior cecal artery. Number one will be your ileocholic artery. Just remember ileocholic artery. And appendicular artery comes from ileocholic artery. Okay. Appendicular artery comes from ileocholic artery. Ileocholic. Then we have let me show you. Let me remove this one. So then we have right cholic artery. Okay. After ileocholic artery, we have right cholic artery. Okay. Then we have, forget marginal arteries, middle cholic artery. Okay. So let me show you because this model is for showing. We have all written in notes, but still we have to show so you can remember. So this is the superior mesenteric artery. Remember ileocholic artery, right cholic artery, then middle cholic artery. Okay. Ileocholic artery, right cholic artery, middle cholic artery. Now, then we have at inferior mesenteric artery at our vertebral level L3. This inferior mesenteric artery, we need to add the branches. Okay. So from inferior mesenteric artery, first thing you need to know is this one. That is left cholic artery. Why this is important? Because see, let's hide this thing, duodenum. And we can see that this is our middle cholic artery and this is our left cholic artery. I'm touching the branches. So you can see that left cholic artery is the first branch of inferior mesenteric artery and middle cholic artery is the last branch of superior mesenteric artery. Now what happens? Let me simplify it. If due to any reason this left cholic artery is blocked, then middle cholic artery will supply this area. Middle cholic artery will give additional supply to this area. And again, If due to some reason this artery is blocked, that is middle colic artery, this is not working, then left colic artery will supply this area. So they're friends, they back up each other. That's it. So this is the first thing you need to know from inferior mesenteric artery. Then what about other branches? They will never ask you about other branches, but they will not ask you branches, they will ask you these kind of questions. Then what happens, just remember, sigmoid arteries, then superior anorectal arteries. Superior anorectal arteries. Rectum blood supply, they never ask. They just ask about lymphatic drainage. They never ask. Just know this for now. Just see these things for now. Then, then I'll talk about arteries, and then I'm going to show you. Let me just hide the arteries. Digestive system. Let me show you the kidney, because let me show you the kidney. Okay, let me show you the kidney later on. First, let me show you the pancreas. So why I'm showing you the pancreas? So pancreas, first thing you need to know that tail injury, tail have all the beta cells, and we have head, neck, body, tail. Most common site of necrosis is the body, and this is our uncinate process. Uncinate process. Okay. So between body and uncinate process, we have a very important structure, and that is, I have to show you, that is our this artery, that is superior mesenteric artery. Let me add the veins too. So here we have it, superior mesenteric vein, superior mesenteric artery. Now if we add the digestive system, so layer by layer you can see things get complicated, right? But I'm here to make this simplified, don't worry. So this is over the third part of duodenum, and it's coming out through uncinate process. And see, this looks like a thumb. This looks like a thumb and hand. Okay, and if we if we give a nut here, we can crack it. So so it is a nutcracker situation. So due to any reason, if superior mesenteric artery dilates, superior mesenteric artery dilates, or something happens, it will block the duodenum, right? And again, due to any reason, if pancreas has a neoplasia or something, or abnormal growth, it can compress these two, right? It can compress these two, superior mesenteric artery and superior mesenteric vein. Just see, and you will understand. You will understand the questions. Now, this is not the end. This is not the end. See, let me show you one thing. That is, they ask this question that duodenum is dilated. Okay, so what can be the reason? So the reason can be that superior mesenteric artery aneurysm or something that's pressing over the duodenum. This can happen. Again, then we have, so let's go to kidney now. So this one was left, so I had to show it. Okay, we hide it, and we can say that we have renal pelvis, then we have ureter. Okay, so what's the content of renal hilum? Vein, artery, pelvis. So we'll have vein, then we will have artery, then we will have pelvis. You can say that there's a problem. What's the problem? The problem is kidney. Uh, Give me a moment. Let me hide it first so I can show you clearly. So you can say it that this thing, superior mesenteric artery and left renal vein, has some problem in between them. What's the problem, guys? Again, if superior mesenteric artery dilates, behind it we have left renal vein. Why? And you can see that left renal vein is slightly bigger than right renal vein. See, this is our right renal vein. See, this is our left renal vein and this is our right renal vein. See, this is very short. This is very short and this one so big. And above it, we have superior mesenteric artery. Again, there is a thumb and there is a hand. And due to aneurysm or dilatation of superior mesenteric artery, it can block this left renal vein. Now, what's wrong if you block left renal vein? Guys, see, this is slightly to the right. Okay. And we have left suprarenal vein and left gonadal vein, like from in case of male testicular, in case of female ovarian, right? So we will have this gonadal vein and right suprarenal vein, guys, left. So left gonadal vein and left suprarenal vein is draining into this left renal vein. So if it gets compressed, the drainage is impaired. Impaired. So what will happen? Drainage is impaired. So you can get hydronephrosis, of course. Your kidney will bloat. And then again, your testicles will be heavy and drainage is impaired. Drainage is impaired because the the venous return, the like not venous return, what would I say? The blood that was coming from testes, that draining, that's stuck here. To put in normal words, that's stuck here. So you will get these symptoms and you will have left sided varicocele. Varicocele. Okay. So there will be heavy testis and a boggy warm sensation. Warm. Okay. So this is called nutcracker syndrome. Okay, this is called nutcracker syndrome. This is important. Now, then we have the ureter. Then we have the ureter. Let me add the bones. So, why am I adding the bones for the ureter? So that you can see that the ureter is along the transverse process of lumbar vertebra. Transverse process of lumbar vertebra. So if you get a stone, ureteric stone, you will check along the transverse processes because the stone will be over this line. You cannot see the ureter, but you can see the stone. So you will have to find it right like this. Okay. So that's the important thing about ureter. Then ureter will go down and enter into the bladder. Enter into the bladder. Enter into the bladder at the trigone of urinary bladder. At the trigone of urinary bladder. Okay. And behind it, you can see, I mean, above it will be ductus deferens and it will go behind and it will become, let me show you what it will become. Okay, let me just hide it. See, and it will become seminal gland. Okay, no, guys, it will go into seminal gland. Okay, it will go into seminal gland. Okay, and it will enter your prostate. Okay, it will enter your prostate. Now, you can say why it will enter your prostate. Which lobe, what, they will not ask where it will enter. They will not ask. See, this is our seminal gland and this is our prostate and this is our urethra, that is prosthetic urethra. This is the starting of our urethra. Okay, and prosthetic urethra. And these are opening here. So from here we get semen, from here we get sperm, right? From here we get sperm from testis. This is coming from testis. We get sperm. And from these secretions we get semen, right? And these are opening into prostate as ejaculatory duct. Let me show you. We hide it. We hide it. So this is our ejaculatory duct that is opening in the prostatic part of the urethra. This is our ejaculatory duct that's opening in our prostatic urethra. That is our first part of the urethra that's inside the prostate. That's inside the prostate. Forget utricle, this is our ejaculatory duct. So from ductus deferens, we will get sperm, then we will have this seminal gland, and these two will become ejaculatory duct. This ejaculatory duct will open into prostatic urethra, and after it passes the prostate, we get male external urethral sphincter. That is a membrane like structure, and so we will have inside it membranous urethra. Simple. So urethra, first part prostatic urethra, ejaculatory duct is opening here, and sperm will come here, semen will come here. Then we will have membranous part, that is membranous urethra, that's inside your external urethral sphincter. Okay. This is called membranous urethra. That's the second part. And see, this is a narrow part, and prostatic part is the widest part. You can see it very clearly. So this is the narrow part of the urethra. Then we have bulbourethral gland that's opening outside the perineal membrane. Okay. So here we have perineal membrane and we have membranous urethra. Yes. So here we have the bulbourethral gland. We hide it and we hide the membrane too. Okay. Okay. We hide it. So pubococcygis, we hide it. Puborectalis, we hide it. Right now we don't need that. So deep transverse, not need, we don't need that right now. Perineal membrane. Then we have, so you can see it now. So here we have bulbospongiosus muscle. Okay. And this is our bulbourethral gland that's opening at spongy urethra first part. That is, we call it bulbar urethra. Bulbar urethra, because bulbourethral gland opens here, we have, and that's why it's called bulbar urethra. So prostatic urethra, membranous urethra, that's the almost, I would say, narrowest part. And if when you insert a catheter, you will have a resistance here. Okay. So then we have bulbourethral gland, then we have bulbar urethra. Okay. Bulbar urethra, first part of spongy urethra. That's it. So these are the parts of ureter and urethra. And now we see from front. We hide it, we hide it. Okay, we hide it. So we can see. the rest of it. So this is our whole urethra, spongy urethra right there. This is our spongy urethra right there when we see from side. So this is our tunica vaginalis parietal layer. We hide it and we can get the tunica vaginalis visceral layer. Okay. So tunica vaginalis visceral layer. There we have lobules of testis. We hide it and we can see here. See, this is our reti testis. Then we have efferent duct. Then we have epididymis. Okay. And that after that we get ductus deferens. So these are our lobules of testis. Just see. Then we have reti testis. Then we have efferent ductules. Then we have epididymis. Then we have ductus deferens. Then we have seminal gland. Then we have ejaculatory duct. And this is the pathway of sperm. And see, this is our parietal layer of tunica vaginalis. This is our visceral layer of tunica vaginalis. And if we get a hydrocele, the water is in between these two layers. The water is in between these two layers. Tunica vaginalis parietal layer and tunica vaginalis visceral layer. These are the things, very important things you need to know. This is our corpus spongiosum and this is our spongy urethra because it's inside corpus spongiosum. That's why they named it like this. So this is our ureter. Okay. So this is all about ureter. You need to know. You need to know the blood supply of the ureter. Okay. Let me hide these things. We hide it. We hide it. So these are bladder, everything. And remember detrusor muscle, we have it all the notes. I will tell you from those notes now. Let me show you abdominal aorta and its branches. This is very important. So as we have talked about some arteries, you can see that abdominal aorta is giving three openings in front. One little forget it. So three openings in front. That is at T12 level we have sun-like or celiac plexus. Then at L1 we have superior mesenteric artery. At L2 we have three branches from these sides. I'll show you. Renal, suprarenal, gonadal. Gonadal means in case of male it's testicular, in case of female it's ovarian. Then we have inferior mesenteric artery at the level of L3. Okay, this is the normal general level. It can vary slightly from person to person due to anatomical variations. That's not important. Then behind, just remember lumbar branches. Okay, now let me show you these branches. Superior mesenteric artery, inferior mesenteric artery. From sides, we get renal artery, renal artery, renal artery, renal artery. Then, if we add more, we can see that we get suprarenal, renal, and we don't have gonadal right now. Suprarenal and renal. Suprarenal and renal. Okay, so one last thing I need to show you. No, I have to show you that internal iliac artery branches. So abdominal aorta will divide into common iliac artery. Common iliac artery will give you, see, ureter will cross this common iliac artery. Okay, so here we have a constriction. We'll talk about that later because you cannot see constrictions here. So inferior mesenteric artery right now, we don't need that. So external iliac and internal iliac artery. Internal iliac artery will supply all your pelvic organs. It will give one posterior division and one anterior division. Posterior division will supply back of your pelvis, that is glutes. Let me add the branches. Let me add the branches and you can see we hide it. We hide it. These are not important. See, it will give superior gluteal artery. That's the most important thing you need to know. That posterior deviation will give superior gluteal artery, and this is our piriformis muscle. Above piriformis, superior gluteal artery, superior gluteal vein, superior gluteal nerve. Okay, these are not important. Lateral sacral, forget it. Let me add branches of this one too. Okay, so first thing, umbilical artery, forget it. We will not have it in uh, adult male. It obliterates. Okay, so first thing, superior vesical artery that supplies the superior parts of bladder. Then you will have obturator artery. Then we will have inferior vesical artery. So superior vesical, inferior vesical. Then you will have middle and middle rectal artery. Okay, superior rectal artery, we were having it from inferior mesenteric artery. Middle rectal artery, then we have internal pudendal artery, then we have inferior gluteal artery. Most of the time they ask about vesical artery and inferior gluteal artery. So these are the branches of internal iliac artery. Now let me show you one thing. If we add veins, you can see that left common iliac vein is under our common iliac artery. Which one? Right one. So right common iliac artery is above left common iliac vein. See, see. So if we have an aneurysm here, if we have a dilatation or aneurysm here, this venous drainage will be blocked, and all of your left leg will be deprived of venous drainage. So you will have edema of the left leg, edema of left leg, whole of it. So anytime you get an edema of left leg, your first concern would be checking this artery, that is right common iliac artery. Right common iliac artery. And for that you have to do an USG first. That's it. So these are something they ask. Okay. So that's how our 3D teaching ends. Then we will start the notes. So let me take a 5-minute break. Then I will start the notes. What you have to study, like all of the important things I have shown you from 3D. Then we'll go to notes. Okay, guys, I'm coming back in 5 minutes. Okay, I'll be giving you a new link after 5 minutes so that the 3D and notes portion stays short, so you can see separately, or it's easier to see if the classes are short.